Tendinopathy is a widespread issue affecting both athletes and the general population, leading to pain and impaired function. It's a condition marked by changes in tendon structure, such as disorganized collagen and increased ground substance, rather than just inflammation. Clinicians from various specialties encounter tendinopathies frequently, making it essential to understand their diagnosis and management. Process typically involves a targeted patient history, clinical examination, and selective imaging if needed. While tendinopathies share common pathological features, each anatomical region presents unique symptoms and requires tailored treatment strategies. In this video, we'll explore the diagnosis, evaluation, and management of 6 common tendinopathies, highlighting recent advances and best practices. Rotator cuff tendinopathy is a frequent cause of shoulder pain, especially in individuals over 50, those with diabetes, or those who perform repetitive overhead activities. Acute injuries often result from trauma, leading to tears or tendinitis, while chronic overuse causes tendinopathy. The supraspinatus tendon is most commonly affected, but other muscles like infraspinatus, teres minor, and subscapularis can also be involved. Patients typically report dull, diffuse pain in the anterolateral shoulder worsened by active movement. Diagnosis relies on clinical history, specific maneuvers, and imaging such as X-ray, MRI, or ultrasound. Treatment starts with activity modification, NSAIDs, and physical therapy focusing on eccentric loading. Advanced interventions like PRP and shockwave therapy offer short-term relief, while surgery is reserved for refractory cases. Medial epicondylopathy, also known as golfer's elbow, affects the attachment point for several forearm muscles. It's common among athletes and laborers who perform repetitive wrist flexions such as golfers, baseball pitchers, and bowlers. Patients present with medial elbow pain radiating into the forearm, often worsened by wrist flexion or pronation. Examination reveals tenderness just distal to the medial epicondyle, swelling, and pain with resisted wrist flexion. Imaging is usually not necessary but can help clarify diagnosis in uncertain cases. Treatment centers on activity modification, formal physical therapy with eccentric loading, and sometimes counterforce bracing. PRP and shockwave therapy may benefit refractory cases, but caution is advised with steroid injections due to rupture risk. Surgery is considered only when conservative measures fail. Lateral epicondylopathy, or tennis elbow, is more common than its medial counterpart and affects the wrist extensor tendon at the lateral epicondyle. It's frequently seen in racket sports and manual labor involving repetitive wrist extension or gripping. Patients report lateral elbow pain, especially with wrist extension, often following repetitive activity. Examination shows tenderness distal to the lateral epicondyle and pain with resisted wrist extension, but strength is usually preserved. Imaging is reserved for unclear cases or those unresponsive to conservative treatment. Management focuses on activity modification, eccentric physical therapy, and counterforce bracing. Steroid injections are discouraged due to poor long-term outcomes and rupture risk. PRP and shockwave therapy may help in persistent cases, while surgery is a last resort. Gluteal tendinopathy is a major cause of lateral hip pain and is linked to greater trochanteric pain syndrome. The gluteus medius and minimus muscles stabilize the hip, and their tendons insert on the greater trochanter. Patients, often females aged 40-70, report pain worsened by lying on the affected side or weight-bearing activities. Examination reveals tenderness over the greater trochanter and pain with resisted hip abduction. Imaging such as ultrasound or MRI can show tendon thickening and signal changes but is not always necessary. Treatment emphasizes activity modification and gluteal strengthening through physical therapy, which outperform steroid injections in long-term satisfaction. NSAIDs may help with pain, and advanced interventions like ESWT or PRP are considered for persistent cases. Surgery is rare and reserved for refractory situations. The extensor mechanism tendinopathy, often called jumper's knee, includes quadriceps and patellar tendinopathy. It's prevalent among athletes in jumping sports like basketball and volleyball, and risk factors include male gender, high BMI, and increased training hours. Patients experience pain above or below the patella, worsened by activities like squatting, jumping, or stair climbing. Examination reveals tenderness and limited knee flexion due to pain. Imaging such as ultrasound or MRI can show tendon thickening and neovascularization. Treatment focuses on reducing knee extension activities, eccentric exercises like decline squats, and heavy slow resistance training. Steroid injections are discouraged due to adverse effects, while PRP and ESWT may benefit chronic cases. Surgery is reserved for those who do not respond to conservative therapy. Achilles tendinopathy affects the largest tendon in the body, with limited blood supply and a tendency for chronic injury. It's divided into insertional and non-insertional types, with runners and jumpers at higher risk. Patients report pain during activity, localized swelling, and sometimes decreased performance. Examination includes palpation for tenderness and specific tests like the ARC sign and Royal London Hospital test. Imaging such as ultrasound or MRI can show tendon thickening, calcifications, and neovascularity. Treatment starts with conservative measures, rest, ice, NSAIDs, and eccentric strengthening, often using the Alfredson protocol. PRP and ESWT offer short-term benefits, but long-term outcomes are similar to other therapies. Surgery is considered for refractory cases, with options varying by tendinopathy type. Imaging plays a supportive role in tendinopathy diagnosis, especially when clinical findings are unclear or when patients fail to respond to conservative treatment. Musculoskeletal ultrasound is increasingly popular due to its cost-effectiveness and high sensitivity. MRI is valuable for identifying tendon tears, degeneration, and signal changes. Advanced treatment modalities include extracorporeal shockwave therapy, ESWT, and platelet-rich plasma PRP injection. While these interventions often provide short-term symptom relief, evidence for long-term improvement is mixed. Steroid injections should be used cautiously due to the risk of tendon rupture. Surgery is reserved for cases unresponsive to other treatments with options tailored to the specific tendon and pathology. Tendinopathies are common and often debilitating, but accurate diagnosis and tailored management can lead to optimal outcomes. Across all types, exercise-based rehabilitation, especially eccentric and heavy slow resistance protocols, remains the cornerstone of treatment. Adjunct therapies like PRP and ESWT may offer additional benefits in select cases, but their long-term efficacy is limited. Steroid injections should be used sparingly due to rupture risk. Imaging is primarily reserved for diagnostic uncertainty or treatment-resistant cases. Understanding the nuances of each tendinopathy, including risk factors, clinical presentation, and treatment options, ensures clinicians provide the best care for their patients. When conservative measures fail, surgical intervention may be necessary, but always after careful consideration.